Hi, Mike Gibson, Tim Henry coming to you live from SCAI 2016, talking about stem cell therapy for chronic ischemia with LV dysfunction, the ATHENA study. Tell us a little bit about what you did and why you did it, Tim.
Yeah, so ATHENA, so there's an increasing number of people that have class 3 heart failure that
The walking wounded, you know?
Exactly. That despite optimal medical therapy and device therapy, they are left with heart failure.
Right.
Now, when you have ischemic cardiomyopathy, there's really two groups. One is dead muscle from an old LED infarct to anterior apical aneurysm. But then the second group has ongoing ischemia, so previous bypass, multiple patchy areas of ischemia. So those people with ischemic cardiomyopathy that have ongoing ischemia, what they need is improved blood flow.
Right.
So what we thought is kind of a changing paradigm is to say, why not treat the reason for it? So improve their blood flow. And so the trial involved ATHENA, is patients with ischemic cardiomyopathy, ejection fractions 25 to 45%, class 2 to 4 angina, or class 3 heart failure. So it could be either heart failure or angina. And then what we do is we do liposuction. So,
seems crazy, but tell us why liposuction? Are there some mesenchymal stem cells in there or something?
They are. So, adipose tissue is very full of stem cells.
Yeah.
So, and then it's a mixture of cells. So it's an actually interesting thing because it has CD34 positive cells, which are more like endothelial growth factors and improves in perfusion. And then there's mesenchymal cells. There's also macrophages. So it's really a very appropriate mixture. So it's really a very potent source of stem cells, and it's very simple. So you do liposuction.
So to describe that in detail, what do you mean by liposuction?
Yeah, so you
Real
basically
liposuction?
take a little tube in and suck out the fat, and you don't need 200 to 400 cc's, so a small amount.
And are you doing this as the interventional guy, or is the plastic surgeon come by?
We had the plastic surgeons do it. But there are some interventional cardiologists that have done it, and actually there was an initial trial that was done in Europe with 27 patients, very similar trial design, that showed evidence, at least suggestive evidence that it worked. And many of those actually that did it was done by the cardiologist.
Cool.
But here we had the plastic surgeon do it.
Yeah.
Process the cells in a self-contained process. Takes about 2 hours.
Right on site, because
Right
in
on
some of the other trials, you had to send these away and get them all
Right on site.
right on site.
Right on site.
Okay.
So very simple. Takes 2 to 3 hours, and then take that same patient to the cath lab.
Yes.
Do intramyocardial mapping. With electromechanical
with NOGA mapping and find out what's dead.
To find the area of ischemia.
Or ischemia versus living
That's what we
and
want.
dead.
We want areas of ischemia, and then inject the cells directly into it. And ATHENA 1 was to use 40 million cells, and ATHENA 2 was to use 80 million.
And are you injecting right into the muscle itself?
Right into the heart muscle.
You did that instead of give an intracoronary injection. Why is that? Is this just too viscous, or it might clot, or?
So these are patients with chronic symptoms. I think giving intracoronary delivery when you have an acute myocardial infarction might be okay, but these are chronic, and so I think
it might not even get there. I mean, if they had a TO or something, it wouldn't even get there. So you inject right in,
and secondly, you might actually get plugging because the cells are bigger. These cells are a little bigger, so you might get microvascular plugging.
Right, that's what I was worried about. So what'd you find then?
So it's a great story. It's an interesting story, but it's a little tragic. So first of all, because these are ischemic cardiomyopathy, 1/3 of the patients had atrial fibrillation and were on anticoagulation. So it's a pretty high-risk group. The average ejection fraction was about 30%. So, and over 30% of the patients had had a previous TIA or stroke. So early in the trial, there was one patient that had diplopia.
I see.
So just lasted brief and then went away. So
obviously you're doing TEE and things, making sure you're not going in and injecting in an area of clot, right?
Yes, there's no, at best you can tell, but when you have a big boggy ventricle, you can't always tell. Plus they're on atrial fibrillation, they're off their anticoagulation. because you've done liposuction and intramyocardial injection. And we know that all of these people's aortas are not very good, right? So there's lots of potential reasons. Anyway, very brief, went away. A year and a half later, trial was recruiting well, doing well, and there was a second with some temporary confusion. And so because of that, both of these were possible TIAs, and then there was a built-in stopping rule to stop the trial.
What's that, for stroke or TIA?
For stroke, but they fact both TIA and stroke built in.
I see.
So a wonderful DSMB, we went through everything, we went through the FDA, everyone was good. We just clarified how you would stop the anticoagulation, so we standardized a little better. But unfortunately, by stopping the trial, we injected a delay.
I see.
That then the trial stopped with only 31 patients.
I see. That's unfortunate.
So it is unfortunate because now we have the results and we present the results for the first time tomorrow. And what we saw, it is important to note, completely double-blind placebo-controlled trial. Both groups got liposuction, both groups got intramyocardial injection.
One placebo, one real tissue.
Exactly. And what you saw is there was a significant improvement in the Minnesota Living with Heart Failure questionnaire. There was a significant improvement in the SF-36 in the cell-treated patients. If you look at the percent that had an improvement in either angina or heart failure, roughly 60% of the cell-treated patients improved and roughly 20% of the placebo patients.
Wow.
So all of the symptoms all were in the right direction. If you looked at NVO2, it was about 45-second improvement compared to a 10 decrease. So everything was in the right direction. Now I will say a caveat, no improvement in ejection fraction. So consistent with some other trials recently, you saw improvements in symptoms, improvements in kind of quality of life, but not this improvement in ejection fraction. So the benefit is different than what we think. Unfortunately.
So how do you explain that? I mean, why would there be a benefit without that mechanical benefit?
So it's a really interesting thing. A lot of people are interested in this now. I think it's really immune modulation, that it's anti-inflammatory. We know that a lot of the process of things that are the bad things that happen in the heart are due to inflammation.
Sure.
Apoptosis and all in this process. And it appears that it interrupts that and decreases inflammation. It also, we think, promotes angiogenesis, but you would hope that that would translate into improved function, but not necessarily.
So the angiogenesis might improve the metabolism and the symptoms, ischemic symptoms. It might be too subtle, though, to see maybe on echo or some of the imaging studies, perhaps.
Really important point, Mike, because what we did in this trial is we measured...
And you might improve diastolic function more than systolic function.
And what we did, as everybody knows, we just measured echo.
Right.
So this is more just safety, where it's not a... And in 31 patients, obviously, you're not going to see a difference in echo, especially people whose EFs are 31. You know, they're dilated. It's just not a. It's not a very good tool to do that.
Right.
So I think what we're left with is encouraging that lots of steps in the right direction, almost identical to the trial that was done in Europe, but not enough patients.
Sure.
And I think a lesson is, this DSMB was fantastic, but there was this arbitrary stopping rules that we were, and the investigators wanted to be, you're very conservative, you want to present anything. Well, it turns, both of these patients ended up fine. There was a third one that had a possible, but there was really no real strokes, all just 3, and 2 are in the treatment group, 1 in the placebo, and they were both sort of possible.
Right.
So it's too bad because what we really needed to do was test this in a proper way.
Sure.
And to look at the 2 doses.
Absolutely. Well, we learned something. That's why we do it.
And it certainly is promising. So I think you're absolutely right. When we do design the next trial, we also learn about how to better manage the liposuction injection, how to do the anticoagulation.
Well, now that you're in Hollywood, you should be pretty good at that.
Yeah, we should.
All right, Tim, thanks for joining us today, and thanks to all of you for joining us here live from SCAI 2016.